In the next half hour, we'll look at the brachial plexus. So basically, the outline for the next half hour will encompass imaging techniques, anatomy of the brachial plexus, and then we'll look at traumatic and non-traumatic causes of brachial plexopathies. They're about 50%. And the most important thing in clinical practice becomes radiation fibrosis and differentiating it from neoplastic involvement. There are many imaging techniques that can evaluate the brachial plexus. However, MR is the optimal imaging modality because of its high soft tissue contrast and ability to differentiate intravascular flow, as well as its multiplanar capabilities. CT limitations include beam hardening artifact and poor differentiation of the brachial plexus from adjacent vascular structures. There have been recent reports of ultrasound imaging of the brachial plexus, but still, ultrasound cannot entirely image the entire course of the brachial plexus secondary to bony landmarks and depending on the patient's body habitus. So what we tend to do is do two separate sequences where we image both right and left. We tend to do the symptomatic side first. We use a large field of view, and then we do T1 weighted images in the axial, coronal, sagittal planes, followed by an axial T2 weighted image. We tend to do the sagittal images in a somewhat oblique orientation, routine cases without gadolinium, and what becomes really important is that the coronal images are ideal for surveying the entire course of the brachial plexus, and sagittal images are useful in evaluating the divisions and chords. So the brachial plexus is a major neuronal structure providing motor and sensory innervation to the upper extremity. And the key is understanding the normal anatomy in order to interpret brachial plexus abnormalities. This is a diagram which demonstrates the brachial plexus coursing from the neck through the scalene muscle into the supraclavicular fossa, then coursing under the clavicle, and then going in the infraclavicular fossa out into the axilla. And you can notice from this diagram that this has somewhat of an oblique orientation, and that's why the sagittal oblique may be beneficial in really looking at the course of the brachial plexus. The brachial plexus is formed by the ventral nerve roots of the C5 through T1 spinal nerves. This is in the majority of individuals. Occasionally, there can be minor contributions from C4 and T2. And these nerve roots then join to form the trunks, the divisions, the cords, the peripheral nerves, which are the terminal branches. And a good little mnemonic to remember these divisions are radiology texts drink cold beverages. So R is for the root level, T is for trunks, D is for divisions, C is for cords, and then B is for the branches. So you have three trunks, and you get the upper trunk, which is the formation from the C5 and C6 spinal nerves. The middle trunk is the continuation of the C7 nerve root. And the lower trunk is formed from the C8 and T1 nerve roots. And these trunks then course superior and posterior to the subclavian artery and through the supraclavicular fossa. Each trunk then separates into an anterior and posterior division within the supraclavicular fossa. The divisions of the superior and middle trunk form at or lateral to the anterior scalene muscle complex, and the divisions of the lower trunk form at or after it crosses the first rib. The three cords are then formed from the divisions. The cords are named for their relationship to the subclavian artery. So we have a lateral cord, which consists of the anterior divisions of the upper and middle trunks, the posterior cord, which consists of the posterior divisions of all three trunks, and hence this has all the components of the brachial plexus. And then finally, the medial cord, which is the continuation of the anterior division of the lower trunk. The cords then travel between the clavicle and first rib, where they enter the axilla, where they divide into the peripheral branches or the peripheral nerves, the musculocutaneous, the axillary, radial, median, and ulnar nerves. So this is a sagittal image looking at the intrascalene triangle, which we can identify at the trunk level. So here we have the clavicle, the subclavian vein. We can see the anterior scalene muscle, and then we have the medial and posterior scalene complex, and we have this triangle. We have the subclavian artery, and on top we have the upper, middle, and lower trunks. And what we tend to see on a T1 weighted image is somewhat hypointense or isointense components to the brachial plexus. At the costoclavicular space, which is posterior to the clavicle and anterior to the first rib, again, we have the subclavian vein, we have the subclavian artery, and just superior to that, we can see these fine little dots, which are at the division level of the brachial plexus. And then as we move more laterally into the retropectoralis minor space, so we have the pec major muscle, pec minor muscle, and at this level, we start to visualize the chords. So here's the subclavian artery, subclavian vein. So we have the lateral, posterior, and medial chords. This is a coronal T1 weighted image, and the beauty of looking at these coronal images, it gives us a survey of the entire course of the brachial plexus. So we have the subclavian vasculature, and we can see that the brachial plexus is running superior and slightly posterior to the subclavian artery. And one of the nice things about looking at these coronal, again, we can see it coming from the neck within the scalene triangle and then follow it along into the axilla. On sagittal images, again, we can follow from the costoclavicular space out laterally to the pectoralis minor space, where we can go again from the division level to the chord level. On axial images, what's important to do is look at the spinal column, look at the neural foramen, and then we can try to trace out the nerves as they are exiting through the neural foramen out into the scalene complex and then going into the supraclavicular fossa. Traumatic plexopathies are about 50% of brachial plexopathies. Post-traumatic injuries can cause compression, stretching, or tearing of nerve roots. Injuries include fracture of the spine or clavicle, avulsion of nerve roots with or without pseudomeningocle formation, soft tissue edema, or hematoma. The two major causes of nerve root avulsion are traumatic injuries, typically at birth or usually in young adults involved in motorcycle accidents. We can further characterize traumatic plexopathies into a preganglionic etiology, which tends to be intradural, or postganglionic, which may be peripheral nerve injury. So in the past, it was believed that myelography and CT myelography may have been more sensitive in detecting nerve transactions and nerve root injuries. But it's been shown that it may be equal to MR sensitivity. So on MR, what we can look for again are nerve root avulsions. We can see pseudomeningocle formation. We can see lateral displacement of the cord, hemorrhage, spinal cord edema, and finally, we can see the sequela of injury to the brachial plexus, which is denervation atrophy of the shoulder and chest wall musculature. This is a patient who was a 25-year-old who had recent subacute injury. He was involved in a motor vehicle accident and presented with right hand pain. So if we look at the sagittal images from a T1, T2 weighted image, we can get the hint that there is some more avid hypointense signal within the neural foramen. If we look at this level, we can kind of make out maybe a nerve root. We can make out a nerve root within the neural foramen more inferiorly, but at this level, we don't really see a good nerve root. This is where the axial images are very helpful. So here at the C5, C6 level, we can kind of see this little outpouching. Get the hint that there is a nerve root, but as we get to the C6 and C7 level, again, we have a pseudomeningocle formation, and we have absence of the nerve root coursing through the neural foramen. And this is helping us identify the avulsed nerve root as well as the pseudomeningocle formation. This is another patient, a 31-year-old, who had a long history of previous trauma with subsequent development of a brachial plexopathy. So if we look at the sagittal T2 weighted images from the patient's cervical spine, we can see marked enlargement of the neural foramen. And again, don't really see any nerve roots coursing through the neural foramen. If we look below, we get the hint that there are nerve roots coursing through. If we look at the axial image, again, no nerve roots, pseudomeningocle formation. The coronal T1 weighted image and sagittal T1 weighted image from the brachial plexus study. And if we look on the left side, we can see the nice muscles of the shoulder and chest wall, whereas on the right side, we can see marked atrophy and fatty predominance. And again, if we look at the sagittal image, we can still see the division level of the brachial plexus, but marked fatty predominance. This is another patient who had recent traumatic injury. This is a T1 weighted image. It's kind of hard to see, but the fibers are somewhat indistinct. If we look at much closer, you can see that we can't really make out the course of the brachial plexus as it's exiting through the scalene triangle into the supra and infraclavicular fossa. The nerves looks very indistinct, no good look at the cords and divisions. Here's the T2 weighted axial images where we can see that there's surrounding hyperintense signal, and this is the adjacent edema causing the brachial plexus injury. This is another patient, again, with long-standing brachial plexopathy who developed denervation atrophy. Again, you can see from the right to left, we look at the atrophy of the muscles along the chest wall as well as along the shoulder girdle. In terms of non-traumatic plexopathy, this is another 50% of all brachial plexopathies. Radiation fibrosis is maybe about 1/3 of all non-traumatic causes. Metastatic disease is probably about 20 to 25%, and then primary lung cancer. What becomes really important in clinical practice is differentiating radiation fibrosis from metastatic disease. And this sometimes may be somewhat difficult to do. Frequency of radiation injury is low, is less than 1%. This may be seen several months to years post-treatment. Typically, the peak is anywhere from 10 to 20 months. These patients tend to present later than metastatic involvement. They're typically associated with radiation doses greater than 60 gray, and clinically they present with paresthesias rather than pain, and if pain is present, is not as severe as with metastatic involvement. And they may present with lymphedema. Typically, in terms of neurologic manifestations, they typically have an upper involvement of the brachial plexus, so C5, C6, C7, as opposed to lower nerve root involvement. With MR, the key is to see no discrete mass. We may see diffuse thickening of the brachial plexus. And it's been described that we may see soft tissue changes with similar signal intensity to muscle on T1, T2 weighted image. One of the keys looking at radiation fibrosis is to identify hypointense signal on the T2 weighted images. However, it's been shown by numerous authors that this depends on when scar forms. Typically in an early setting post-radiation therapy, you may get hyperintense signal, and so it may not always necessarily be the case. In terms of enhancement, both metastatic disease and radiation fibrosis from vascularized scar tissue may also enhance, so it may not necessarily always be beneficial. This is a 77-year-old female who underwent a lumpectomy who presented with lymphedema. So if we look at the left side, we can see diffuse thickening of the brachial plexus, again, coming from the scalene triangle and going out to the axilla. One of the things that's very important to do is do bilateral imaging because we can compare it to the contralateral side. And again, this is what the normal course of the brachial plexus should be, going from the supraclavicular fossa out to the axilla following these subclavian vessels. Here's sagittal imaging. Again, I can't really make out the subclavian artery and vessels, subclavian vein, excuse me, and I can see there's a diffuse soft tissue filling this costoclavicular space where I should see, again, distinct fibers. So this is classic for radiation fibrosis. This is another case that was presented at NYU. This was a 75-year-old who underwent a mastectomy and radiation therapy approximately 3 years ago, who subsequently presented with lymphedema. And if we look at our PET images, we can see that there's a little nodular area of increased uptake, but again, along this course of the subclavian vessel, we see that there's mild uptake of FDG. And if we look at the fused images from the CT scanner, we can see again that there's this increased area of uptake. And we can see it right at the scalene complex. So this was suspicious for radiation fibrosis. And the way we also knew that is we've been following this patient for approximately 2 years. There's really nothing on conventional imaging that really showed a discrete lesion. And it's been described in an article in 1999 in the European literature where PET scanning may be beneficial in looking in terms of differentiating radiation fibrosis from metastatic disease, but it's not something that we routinely do. Metastatic disease is presumed when a mass is identified within the course of the brachial plexus. Metastatic breast disease is the most common neoplastic entity to affect the brachial plexus. Others include lymphoma, melanoma, and lung cancer. Clinically, patients present with early and severe pain, hand weakness, and they may present with Horner's syndromes, and these are more suggestive of tumoral infiltration. The key with MR is to see a discrete mass along the course of the brachial plexus, and with typical findings on T1, T2 weighted images for tumoral involvements, hypointense on T1 and hyperintense on T2. And again, enhancement may or may not be beneficial, but the key is to find a discrete lesion. So this is a 74-year-old female who presented with left arm pain. And if we look at our coronal image, again, we can see this stellate mass in the supraclavicular fossa right above the subclavian vessels. You can see it kind of wrapping around the subclavian artery. You can see it on the axial T1 weighted image, somewhat very stellate soft tissue lesion right at the thoracic inlet. Here's the clavicular head. And again, very ill-defined soft tissue. And on the T2 weighted image, slightly hyperintense. And this was presumed to be metastatic involvement. This is a 43-year-old female with history of breast cancer with left arm pain and supraclavicular fullness. I read this case on a Friday afternoon. One of my colleagues was sort of like, you like the brachial plexus, can you take a look at this case? And I'm like, okay, fine. So we look at the coronal T1 weighted images, and if I follow it out from the scalene triangle out to the axilla, I can see that there's diffuse soft tissue, okay, within the supraclavicular, retroclavicular, and axillary component. Okay, so easy enough. And here's the contralateral side to show you the difference within the left brachial plexus as compared to the right. Again, I can make out the fibers of the brachial plexus, whereas on the contralateral side, this is diffusely thickened. Axial images, it's somewhat iso-intense, doesn't really stand out in terms of hyperintense signal. These are the post-contrast images. So here's the subclavian artery, subclavian vein, and you can see the components of the brachial plexus. Not really enhancing, similar intensity to muscle. So when I looked at this case, I'm like, okay, this is radiation fibrosis, nice diffuse thickening, no enhancement, not hyperintense on signal, and that's the way I had dictated out the case. Well, Monday morning, I get multiple phone calls from the patient, from her internist, from her surgeon, saying that the patient never had radiation therapy. So this is presumed breast cancer metastasis. So again, here's a case where if you look at some of the rules looking for diffuse thickening, didn't necessarily follow. There was no enhancement. It's not really hyperintense signal. And with the history of the patient obviously never had radiation therapy, it would be really hard to say that this was from radiation type of changes. This is another case of a patient who presented with nodal metastases from desmoplastic breast cancer. So if we look out in the axilla, we can see multiple nodular lesions, and this is resulting in compression of the axillary component of the brachial plexus. On the sagittal images, again, this very irregular stellate mass, somewhat nodular, and this is from nodal involvement causing compressive disease. This is another patient with pancreatic cancer who had metastasis. If we look at these sagittal images, we can see a soft tissue mass, which is really better defined on the axial images. It's involving the vertebral body, going out into the scalene complex. We can see it wrapping around the vasculature. This is the cause of her brachial plexopathy. This is another patient who presented with plexopathy, where it was found to be from melanoma. So again, we can see this soft tissue lesion involving the neural foramen going out into the scalene complex. A little closer up, looking at the vertebral bodies on this T1 weighted image, we can see areas of hypointense signal involving the pedicle and posterior elements with melanoma metastasis. And on the post-contrast images, we can see irregular enhancement. This is another patient with non-Hodgkin's lymphoma, where in the superior mediastinum, we see conglomerate nodal masses, again, somewhat hyperintense areas that are more hyperintense within the nodal disease. On the axial T1 weighted image, more ventrally, we can see that this is much more defined, and then we can see some irregular soft tissues, which is, again, better defined on the T2 weighted image, and this is resulting in compressive disease. This is a patient with B-cell lymphoma who didn't want to get an MR, and so we evaluated her on CT. And if we look at the supraclavicular fossa, we can see that there are some ill-defined soft tissue, somewhat much more nodal masses, and again, this ill-defined areas as compared to the contralateral supraclavicular region, and this was from B-cell lymphoma with involving the brachial plexus. Lung cancer can arise, primary lung cancer can arise in the lung apex and invade the lower portion of the brachial plexus. This presents with a characteristic syndrome of pain down the arm and weakness, typically in a C8 and T1 distribution. About 20% may present with Horner's syndrome, which is invasion of the sympathetic plexus. This was described by Pancreatic back in the 1930s. And histologically, 2/3 of these are adenocarcinomas. So here's a patient with right hand weakness. If we look at the coronal images, if we see the axilla, we can say that, okay, here at the division and cord level, we can make out the brachial plexus. If we look in the patient's lung field, there's a large lesion involving the lung apex. And we can kind of see this lip of soft tissue that's extending into the supraclavicular region. Out more laterally on the sagittal image, again, soft tissue mass going into the vertebral bodies. If we look at our axial images, again, irregular soft tissue mass extending into the neural foramen involving the vertebral bodies, again, coursing and wrapping around the brachial plexus and getting the subclavian vessels. On the T2 weighted images, this is somewhat areas that are somewhat hyper intense, more focal areas that are much more hyper intense. But you can see that the T1 weighted images really help us in looking at the extent of the soft tissue. Neuronal tumors can be benign or malignant. They include neurofibromas, schwannomas, and malignant peripheral nerve sheath tumors. The most common involvement are from neurofibromas. However, to differentiate all of these lesions may be difficult on imaging. They tend to be isointense on T1 weighted image and hyperintense on T2, and they typically have avid enhancement. This is an 80-year-old female that we've been following for approximately 6 years. On this T1 weighted image, we can see that there's a well-circumscribed lesion within the supraclavicular and infraclavicular fossa. On the axial T1 weighted image, again, very well-defined, slightly hyper-intense, and this was presumed to be a neurofibroma. This is another case that one of my former fellows sent to me just this past weekend, and I thought it was a really neat case. Here on the sagittal image, we can see a soft tissue lesion, again involving this scalene triangle. We can see that the subclavian artery is somewhat being compressed and displaced inferiorly. If we look at our T2 weighted image, you can kind of see that it's going into the neuroforamen, somewhat heterogeneous, again, widening of the neuroforamen with both a foraminal and extraforaminal component. And we can see on the post-contrast images that there is avid enhancement. And this is presumed to be a schwannoma. Acute brachial plexopathies are known as Parsonage-Turner syndrome. This was described in the 1940s. This is where you can get acute onset of severe and constant pain, followed by profound upper extremity weakness and atrophy. They may be seen post a viral illness or from immunization. They may be bilateral in 10 to 30% of the time. These typically do not go to imaging. They tend to resolve with symptoms. And often with MR, they tend to be normal. What we can see occasionally is signal changes within the shoulder muscle. And this is really more of the findings of the denervation type of atrophy. So in conclusion, MR really is the imaging modality of choice, secondary to its multiplanar capabilities, as well as differentiating soft tissue. And the key really in looking at the brachial plexus is to understand the anatomy. And really, if you trace it on the coronal images, and then follow it on your sagittal images. In terms of traumatic injuries, which may be responsible for about 50%, again, these tend to be in the perinatal period in young kids, as well as young adults from traumatic injuries. And the things to really look for are root avulsion and pseudomeningocle formation, which really clues you in that there may be traumatic injury to the brachial plexus. In terms of differentiating radiation fibrosis from metastatic plexopathy, the key really is to find a focal mass in order to differentiate the two. Sometimes it may be very difficult, as the case I showed you with the metastatic lesion, which was very diffuse in its thickening along the brachial plexus. Enhancement pattern may or may not help you. And signal changes. Scar tissue can be occasionally hyperintense, but classically, what we're really looking for is hyperintense in order to say that it is metastatic involvement. Thank you very much for your attention.